Next is about apheresis. Apheresis means to take away, is a medical technology employed for separating a particular constituent of blood of a donor or patient. Apheresis. In it, the blood is passed through an instrument which separates the constituent and return the remainder of the blood to the circulation. This is a extracorporeal therapy. Blood components are separated either from the blood already collected from a person or directly from his circulation. Based on the components separated, the following types of apheresis can be recognized. Plasma apheresis. In this case, blood plasma is separated and collected as fresh frozen plasma or FFP to be used as when needed. Apart from collecting FFP, this method is also used in collecting immunoglobulin products, plasma derivatives, and rare antibodies. FFP can be stored for 1 year at minus 18 degrees Celsius and up to 7 years at minus 65 degrees Celsius. Then platelet apheresis. This is a separation of platelets and the returning of the RBCs, WBCs, and plasma components to circulation. Then leukophoresis. Leukophoresis, separation of leukocytes, especially polymorphonuclear leukocytes, for transfusion into patients. Then stem cell harvesting, separation of bone marrow stem cells to be used in marrow transplantation. Then LDL apheresis, separation of low density lipoprotein from patients with familial hypercholesterolemia. Then automated red cell collection, removal of RBC. Blood clotting during apheresis is prevented by adding an anticoagulant while the blood passes through the apheresis machine. In apheresis, apart from the desired constituent, a small amount of fluid would also be removed from blood. This fluid loss has to be made up to maintain the normal fluid volume and osmotic balance by the administration of a suitable fluid into the body. So apheresis is significant in that it can be applied either for collecting specific blood components from a donor to be transfused to a recipient or for removing some harmful or disease-causing constituents from blood. In the later case, apheresis has to be carried out quite often when other means to control a particular disease are not successful. And vascular pumps. In animals, blood keeps on occasionally circulating all over the body throughout life. The force responsible for the circulation is provided by the pumping mechanism, which is different in different groups. In some cases, this results from rhythmic pulsations of heart. In some others, from the squeezing of blood vessels during body movements, and in still others, from the peristaltic contractions of the smooth muscle which surround blood vessels. In blood circulation, heart plays a major role in vertebrates. The movement of limbs and the contraction of the dorsal heart are equally important in the arthropods, and the peristaltic contraction of the dorsal blood vessel is important in earthworms. In all animals, the direction of the blood flow is determined by valves or septa in heart or blood vessels, and the amount of the circulating blood is regulated by the sphincters which surround blood vessels. The pumping device is distinctively different in open and closed circulatory systems. In open system, blood is discharged into the hemocoel from where it is drawn again to fill the heart. In this case, the pumping force dissipates in the course of circulation, and so it may not be available for refilling the heart. Therefore, open system require a suction pump mechanism. As the heart contracts, pressure increases, and the inner valves close and the outlet valves open, and the blood is discharged. Refilling is effected by the dilation of the blood, heart, or upstroke. So, closing of the outlet valves, opening of the inlet valves, and aspiration or sucking of blood from hemocoel. Thus, the flow of blood is intermittent and it depends mainly upon the dilation of the heart. On the other hand, a closed circulatory system is steady blood flow is maintained by pressure pump or force pump mechanism. In this case, the major force for refilling is the heart is provided by the low pressure venous reservoir. It maintains a positive pressure within the system. And types of heart. Heart is a central muscular pumping organ which keeps on beating non-stop to maintain a constant circulation of blood all over the body. Based on structure, hearts are classified under 4 categories, namely pulsating vessels, tubular hearts, clumped, chambered hearts, and accessory hearts. Pulsating vessels, these are the contractile blood vessels which function as unspecialized hearts. They are found in amphioxus and many annelids. The rhythmic waves of pulsations or alternate contractions and relaxations passing along their walls and regulatory relays drive the blood slowly in the direction of the waves. The pulsation or peristaltic movement of these vessels are not regular and coordinated. Then tubular hearts. These are contracted tubes without distinct chambers for the separation of arterial and venous blood. They are found in ascidians and arthropods, particularly among insects. Their walls are reinforced by striped muscles. Insect heart has a series of compartments with valvular openings between successive compartments. Each compartment may have a pair of valvular lateral openings called ostia. Since opening between the compartments are valvular, blood always flows from behind forward. In ascidians, heart has no compartments and valves, and so there is a periodic reversal in the direction of blood flow. Then chambered hearts. Chambered hearts. Chambered hearts. These are the specialized type of hearts with distinct chambers for the separation of arterial and venous blood. They are found in cephalopod mollusks and vertebrates. Chambered hearts. These are the specialized type of hearts with the distinct chambers for the separation of arterial and venous blood. They are found in cephalopod mollusks and vertebrates. In fishes, with the exception of lungfishes, heart is two-chambered with an auricle and ventricle. In amphibians, it is trilocular or three-chambered with two auricles and a ventricle. In reptiles, with the exception of crocodiles, heart is incompletely four-chambered with two auricles and partly divided ventricle. In lungfishes, crocodiles, birds, and mammals, heart is typically tetralocular and four-chambered, and two auricles and two ventricles are there. In accessory hearts, accessory in the sense auxiliary or ampullary hearts, these are contractile sacs which supplement the functioning of the heart to robust up the pressure of blood or lymph. The blood pumps of crustaceans, local dilations of blood vessels, the accessory pulsatile ampullar organs of some insects, branchial hearts of cephalopod mollusks, and bulbils of amphioxus, contractile swellings at the base of some blood vessels, and the lymph hearts of vertebrates, etc. are examples. And myogenic and neurogenic hearts, based on the stimulation of heartbeat, two kinds of hearts can be recognized, myogenic and neurogenic. In myogenic hearts, the cardiac muscle fibers have the autonomous ability to initiate and maintain heartbeats without nerve stimulation. So the rhythmicity of the heartbeat is determined by the cardiac muscle themselves. On the other hand, in neurogenic heartbeats are initiated and maintained by nerves control. The hearts of mollusks, tunicates, and vertebrates are myogenic, and those of other animals are neurogenic. Structure and working of human heart. Now we are entering to a major topic. The human heart is a central muscular pressure pump concerned with collection, storage, and pumping of blood. Its rhythmic beating keeps the blood in constant circulation. Human heart is relatively smaller in size, 250 to 400 grams. It is placed in the mediastinal space in between the right and left lungs. It is enclosed within the double-layered membranous bag called pericardium, parietal pericardium, or pericardial sac. The two layers of pericardium are the outer fibrous layer or fibrous pericardium and the inner serous layer, serous pericardium, fibrous and serous layers. The fibrous layer consists of tough collagenous connective tissue. The inner layer or serous layer is thin and delicate, and it is continuous with the outer layer of the heart wall at the base of the heart. The pericardium prevents the over distension of heart, surrounds and protects it, and anchors it in the mediastinum. In between the serous pericardium and the heart wall is the pericardial cavity filled with pericardial fluid. This fluid protects the heart from shock, shake, and friction. Superior vena cava at aorta, right atrium, right ventricle. Inferior vena cava, artery to head, pulmonary artery, left atrium, coronary artery, left ventricle, aorta. Some portions. Then human heart, and we just cut a section. You could see superior vena cava, interauricular septum, right auricle, inferior vena cava, tricuspid valve, pulmonary semilunar valve, right ventricle, interventricular septum, pulmonary vein, pulmonary artery, left auricle, bicuspid valve, aortic semilunar valves, then caudate tendinae, papillary muscles, left ventricle. Human heart is a tetralocular or four-chambered heart organ with two upper and two lower chambers. Its upper chambers are called auricles or aorta and the aortella, atria, and the lower ones are called ventricles. Sinus venosus found in lower vertebrates, which as amphibians and reptiles, has become completely fused with the right auricle. So it does not exist as a separate chamber. Auricles are thin-walled, whereas ventricles are thick-walled and strongly muscular. Externally, auricles are separated from the ventricles below a circular groove called coronary sulcus, and internally by the transverse auriculoventricular septum. The two auricles are separated from each other by the interauricular septum, and the two ventricles from each other by the interventricular septum. On the interauricular septum is an oval depression called the fossa ovalis. It corresponding to an opening of the fetal heart called the foramen ovale. The right auricle receives three major veins. They are the superior vena cava or pericaval vein from the upper part of the body, inferior vena cava or postcaval vein from the lower part, and the coronary vein from the heart wall. The left auricle pursues four pulmonary veins, two from the right lung and two from the left lung. So at the opening of the coronary vein is a semilunar valve. Each auricle communicates with the ventricle of its side through the auriculoventricular aperture, guarded by the auriculoventricular valve. The right auriculoventricular valve has three cusps or flaps, so it is called a tricuspid valve. On the other hand, the left one has only two cusps and hence called bicuspid valve. It is also called the mitral valve. And leading from the right ventricle is the pulmonary artery that carries blood to the lungs. Arising from the left ventricle is the aorta, whose branches supply blood to the different parts of body. At the opening of aorta and pulmonary arteries, a set of three semilunar valves, each known respectively as aortic semilunar valves and pulmonary semilunar valves. Heart wall is formed of three layers: outer epicardium, middle myocardium, and inner endocardium. Epicardium, also called the visceral pericardium, is a thin and transparent connective tissue covering. Myocardium is a layer of cardiac muscle. It is responsible for the contraction of the heart. Endocardium is a thin and transparent endothelial lining. The inner surface of the auricles bears projecting muscle bundles called maculae pectinati. Similarly, the inner surface of the ventricular wall bears numerous muscular ridges called trabeculae carni and numerous muscular projections known as papillary muscles. Auriculoventricular venae valves are fastened to the papillary muscles by means of tough fibrous cords called chordae tendinae, heart strings. These cords hold the valves in position and prevent their backward bending or flexion during ventricular contraction. So, inflammation of the pericardium, epicardium, myocardium, and endocardium are known respectively as pericarditis, epicarditis, and myocarditis, and endocarditis. The right and left halves of the heart are completely separate from each other, since the septum in between them is complete and unbroken. The right half deals only with the deoxygenated or venous blood, and the left half only with oxygenated or arterial blood. Since the right and left halves of the heart are not intercommunicating, these two samples of blood never mix together. Thus, human heart functions as a double pump. Then, electrical and mechanical properties of cardiac muscles. Cardiac muscles are unique in having some characteristics which are specializations for their function. Some of such features are as the following: branching and interconnecting fibers. The fibers of cardiac muscles are cylindrical, striated, uninucleate, branching and interconnecting, and attached to framework of collagen fibers. The interconnection between the fibers enable the spreading of contraction wave all over the heart. Then intercalated discs at the junctions between fibers. At the junctions between cardiac muscle fibers is a dense band known as intercalated disc. It is a kind of gap junction in which two cells overlap only slightly. Intercalated discs are physiologically important in that they are low resistance pathways between cells. They offer only very little resistance to the passage of action potentials from one cell to another. Ions move across the intercalated disc very easily, allowing the entire auricular or ventricular muscles to contract as a single giant cell. In other words, intercalated discs enable cardiac muscle fibers to contract in a synchronous way. By virtue of this property, cardiac muscles are sometimes referred to as a functional syncytia. The auricular syncytium and the ventricular syncytium are separated by each other by fibrous connective tissue. Intercalated discs can boost up the waves of contraction and transmit them from one fiber to another. So they are often called booster rings. They are also significant in that they enable the heart to contract forcefully without ripping the fibers apart. Then tolerance against fatigue. Cardiac muscles are highly immune to fatigue, and so they can go on contracting and relaxing non-stop throughout life. First, intercalated discs are at the junction between fibers, branching and interconnecting fibers. Then automaticity and excitability or irritability. Automaticity is the capability of cardiac muscles to spontaneously generate and propagate action potentials of cardiac impulses. Automaticity is the capability of cardiac muscles to spontaneously generate and propagate action potentials or cardiac impulses. Then tolerance against fatigue. Cardiac muscles are highly immune to fatigue, and so they can go on contracting and relaxing non-stop throughout life. This unique property enables the continuous and rhythmic beating of the heart. Then automaticity and excitability or irritability. Automaticity is the capability of cardiac muscles to spontaneously generate and propagate action potentials or cardiac impulses. In normal condition, this is manifested only in the SA node. Automatic generation of cardiac muscles is intimately related to the rhythmicity of heartbeats. Excitability is the ability to respond to stimuli. This response involved electrical, chemical, mechanical and thermal changes in heart muscles. Electrical changes involve the maintenance of the resting potential and the initiation and propagation of the action potential or action current. Calcium ions stored in the sarcoplasmic reticulum probably play an active role in the electrical changes during excitation. So chemical changes follow electrical events. They include the hydrolysis of ATP and the release of intermediate energy for muscular contraction. Mechanical change involves the contraction or shortening of muscle fibers and an increase in their tension immediately after chemical changes. Thermal changes involve the evolution of heat during chemical changes. Then some other aspects. Elasticity. Elasticity of cardiac muscles is their ability for alternative contraction and distension. Automaticity and excitability or irritability will be there. Then elasticity. Elasticity of cardiac muscles is their ability for alternative contraction and distension. The factors affecting the contractibility and distensibility of cardiac muscles include intensity of the stimulus, initial tension, oxygen level, temperature, calcium content, nerves stimulation, etc. Then rhythmicity. Rhythmicity is the regularity of heart muscles to contract and relax at definite intervals to maintain the constant rate of heartbeats. It is perhaps the most important property of cardiac muscles. It is very intimately related to their excitability and automaticity. Then conductivity. Conductivity is the ability of cardiac muscle to transmit action potentials in regular and rapid release. Normally, rhythmicity and conductivity go side by side. So conductivity enables the excitation and the subsequent contraction of the different parts of heart in regular succession. Then tonicity. Tonicity is the ability of muscles for sustained or continued minimal contraction. In fact, cardiac muscle have no true tone, which is characteristic of skeletal muscles. Then long refractory period. The refractory period of cardiac muscles is longer than the period of actual contraction. This probably avoids tetanic contraction, that is a sustained contraction. Tonicity, conductivity, rhythmicity, elasticity. Then next, long refractory period. The long refractory period is a peculiarity. Then working of the heart. Working of human heart involves regular and rhythmic heartbeats or cardiac rhythms. The interval between two successive heartbeats is called the refractory period. It is often lasts for nearly 0.1 second. Each heartbeat in turn consists of alternative contraction and relaxation of the heart walls. The phase of contraction of the heart wall is known as systole and the phase of relaxation is called diastole. Systole take place in two successive stages, namely first auricular systole and then ventricular systole, but diastole is more or less simultaneous in all the four chambers. So it is called joint diastole. Okay. During auricular systole, deoxygenated blood is forced from the right auricle to the right ventricle, and oxygenated blood is forced from left auricle to the left ventricle. During ventricular systole, deoxygenated blood is pumped from right ventricle to the pulmonary artery for oxygenation of the lungs, and oxygenated blood is pumped from left ventricle to the aorta for distribution all over the body. During auricular systole, blood will not flow back from the ventricles to veins since contraction process from opening of the veins. Backflow of blood to auricles from ventricles is prevented by the auricular ventricular valve. Similarly, backflow of blood to ventricles from auricles is prevented by aortic and pulmonary semilunar valves. During diastole, the chambers of the heart dilate for refilling. And cardiac cycle is the rhythmic and cyclic series of electrical and mechanical events taking place during the heartbeat. It consists of two major sets of events, namely auricular events and ventricular events. These are completed in four stages, namely auricular systole, auricular diastole, ventricular systole, and ventricular diastole. The short interval between the end of one cycle and the beginning of the next is called a refractory period. In a healthy individual, the average rate of heartbeat is 72 times per minute. Then the duration of a cardiac cycle is 60 to 72 is equal 60 by 72 is equal to 0.83 seconds. The duration of cardiac cycle is inversely proportional to the rate of heartbeat. Then is about auricular systole. First, auricular systole is a spontaneous synchronous contraction of the right and left auricles. Auricular systole is completed in two steps, namely a dynamic phase and the adynamic phase. Dynamic phase and adynamic phase. The former is the first half and the later in the second half. In the dynamic phase, there is a maximum contraction of the atrial walls. In the dynamic phase, only up to 30% of fibers contract and only 20% of the blood passes to the ventricles. The increase in arterial pressure resulting from auricular systole is called alpha wave. The blood pressure in the ventricles of the termination of auricular systole is called ventricular end diastole pressure or VEDP. It sets the preload for the next ventricular systole. Then auricular diastole. Auricular diastole immediately follows auricular systole. Its first half almost coincides with ventricular systole. During it, the AV valves remain closed so that blood from vena cava and pulmonary veins accumulate in the auricular cavities. Then ventricular systole. Ventricular systole is completed in two steps, namely isometric or isovolumic contraction phase and the ejection phase. During the contraction phase, ventricular muscles contract, exerting pressure on the blood inside the ventricles. The increased pressure causes the complete closure of the AV valves. This in turn prevents the backflow of blood to auricles. A sudden closure of the AV valve produces the first heart sound S1, which is a slow frequency sound. Thus, the first heart sound marks the onset of ventricular systole. Similarly, the high frequency heart sound marks the end of ventricular systole. And the AV valve closed, the ventricular volume remains constant until the ventricular pressure exceeds the arterial pressure. The ejection phase involves the emptying of the ventricles. It begins when the ventricular pressure exceeds the arterial pressure. This increased ventricular pressure causes the opening of aortic and pulmonary semilunar valves and the subsequent ventricular ejection. So, ventricular ejection causes the flow of blood into the aorta from the left ventricle and to the pulmonary trunk from the right ventricle. The volume of the blood ejected per beat is called a stroke volume. The ventricular ejection phase has two stages, namely rapid ejection phase or maximum ejection phase and reduced ejection phase or slow ejection phase. The former consists of the first 1/3 of the ejection phase. Nearly 80% of the stroke volume is ejected during it. The later consists of the remaining 2/3 of the ejection phase. Only 20% of the stroke volume is ejected during it. Then protodiastole. Reduced ejection phase is immediately followed by a very brief phase called the protodiastole, nearly 0.015 seconds. During this phase, there is a backflow of blood at the root of the aorta due to the rapid fall of the ventricular pressure. This backflow slightly increases the ventricular volume. The protodiastole ends with the closure of the semilunar valves. The closure of these valves in turn results in an abrupt arrest of ventricular ejection and the production of the second heart sound S1, making the end of ventricular systole. And ventricular diastole. Ventricular diastole is completed in two major steps, namely isometric or isovolumic relaxation phase and filling phase. The relaxation phase extends from S2 to the opening of the AV valve. At the beginning of this phase, ventricles are closed as isolated chambers. Then ventricular muscles relax with the result that intraventricular pressure falls steeply below the arterial pressure. This causes the opening of AV valves for filling the ventricles. The opening of the AV valves causes the production of third heart sound S3, which marks the beginning of the filling phase. Filling phase consists of three stages, namely first rapid filling phase, reduced filling phase or diastasis, and the last rapid filling phase. The first rapid filling phase involves the opening of the AV valves and the rapid flow of blood from auricles to ventricles. Nearly 70% of the blood from auricles flows to ventricles during this phase. Then during the reduced filling phase, the auricular and ventricular pressure rise slowly as blood returns to heart. As a result, the flow of blood from auricles to ventricles become very slow. Nearly 10% of the blood from auricles flows to ventricles during this phase. During the last rapid filling phase, the remaining 20% of the blood from auricles flows to these ventricles due to auricular systole. The last rapid filling phase overlaps auricular systole. The forcing of blood to ventricles by auricular contraction produces the fourth heart sounds, S4. Then is about refractory period. This is the short interval or resting period between two successive heartbeats. During it, cardiac muscles will not usually respond to stimulus, even though the stimulus is strong enough to evoke an action potential. Refractory period consists of three phases, namely absolute refractory period, relative refractory period, and effective refractory period. ARB is the initial phase during which the excitability of cardiac muscle is zero and the muscle fibers remain absolutely in a depolarized state. So a stimulus, however strong it might be, will not elicit a response action potential. ARB may continue even after the resting potential has stabilized. RRP follows ARP. During it, there is a graded or progressive return of excitability and the muscle fiber return to the depolarized state. So a strong initial stimulus, stronger than the normal, may elicit an action potential. ERB represents the very short terminal phase of the refractory period. During it, a response action potential would be initiated but would not be propagated. So the muscle cells produce a response which is not transmitted. Then automatic rhythmicity of heartbeat, cardiac rhythm, pacemaker and conducting system. Automatic rhythmicity or cardiac rhythm is the ability of the heart to beat regularly, rhythmically and automatically. This in turn results from a wave of electrical potentials called cardiac impulses. These impulses spread all over the heart muscle. In myogenic hearts, they are initiated independently by a specialized cardiac tissue called the nodal tissue without any nerve stimulation. So the pacemaker activity of myogenic hearts resides in the nodal tissue. Though cardiac impulses in myogenic hearts are absolutely non-nervous in origin, the rate and frequency of their formation and the velocity of their transmission are under nerve control. The nodal tissue is formed of specialized impulses conducting muscle cells that are histologically different from the general cardiac muscle fibers. The tissue consists of two contraction centers and a system of conducting fibrils. The contraction centers are the sinoatrial node, SA node, and the atrioventricular node, AV node. SA node is located near the opening of the superior vena cava and AV node in the intra-auricular septum. SA node is believed to be the remnant of analog of the sinus venosus of lower vertebrate. It contains two types of cells, namely pacemaker cells or P cells and transitional cells or T cells. P cells independently elicit cardiac impulses for every contraction. T cells transmit these impulses to the auricular muscles and stimulate them to contract. An AV node is richly supplied with fibers from sympathetic nerves and vagus nerve. It is the only pathway for excitation to travel from auricles to ventricles. Its cells transmit impulses more slowly than done by other parts of the conducting system. So there will be a very brief time lag while the impulses pass through the AV node. This enables auricles to complete their transcription efficiently. So before the beginning of ventricular systole, the conducting system consists of specialized bundle of tissues known as bundle of His or auriculoventricular bundle. It leads down from the AV node, then divides into two branches and each branch passes to the ventricle of its side. In the ventricular wall, it breaks up into branching fibrils known as Purkinje fibrils. These fibers ramify all over the ventricles. Then right auricle, SA node, AV node, right ventricle, left auricle, bundle of his, left ventricle, and Purkinje fibers. These are the portions. Then during systole, the SA node independently elicits pacemaking cardiac impulses and initiate heartbeat. So it is described as the heart of heart. It is also called a pacemaker or pace setter, since it sets the basic rhythm and determines the rate of heart beat. From the SA node, the excitational waves soon radiate all over the auricle. This causes auricular systole. The impulses then reach the AV node. From there, they are relayed or transmitted to the ventricular walls through the bundle of his. Purkinje fibrils spread the waves of excitation all over the ventricles. This causes ventricular systole. So cardiac impulses cannot straight pass away from auricles to ventricles, since auricular muscle fibers are not continuous with ventricular fibers. The neural regulation of heartbeat. Human heart is myogenic. So in it cardiac impulses are elicited without nerve stimulation. However, the rate of their formation and velocity of their transmission are under the control of the nerve system. The nerve components concerned with cardiac regulation include two brain centers and the nerves which innervate the brain. The brain centers are called cardioregulatory centers. They are located in the medulla oblongata. One of them are excitatory and the other one is inhibitory in action. They are known respectively as cardioexcitatory and cardioacceleratory center and cardioinhibitory center. The nerves which innervate the cardiac muscles include the sympathetic nerve system and the branches of the vagus nerve. The sympathetic system joins the cardioacceleratory center and the vagus nerve joins the cardioinhibitory center. Under the influence of excitatory center, the nerve endings in the sympathetic system release noradrenaline. Similarly, under the influence of the inhibitory center, the vagus nerve endings release acetylcholine. So, noradrenaline activates the SA node and constricts arteries. This in turn increases the rate and force of heartbeat, elevates the pulse rate and reduces the BP. On the other hand, acetylcholine inhibits the SA node and dilates arteries. This in turn decreases the rate and forces of heartbeat, reducing the pulse rate and lowers the blood pressure. Thus, normal heart rate, pulse and BP depend on the balanced interplay between excitatory and inhibitory cardioregulatory centers of the brain. Hormonal regulation of heartbeat. The hormones which regulate heartbeat and control cardiac rhythm include adrenaline, thyroxine, and vasopressin. Adrenaline is secreted by the adrenal medulla, thyroxine by the thyroid gland, and vasopressin by the hypothalamus. Adrenaline accelerates heartbeat, constricts blood vessels, elevates BP, promotes blood clotting, and increases the RBC count. Thyroxine increases heart rate, vasopressin induces vasoconstriction. Then hemodynamics. Hemodynamics is a study of the physical principles, mechanisms, and energetics of blood pressure and blood circulation. In brief, it is a study of blood flow and blood pressure. The French physician, physiologist, and physicist Foucault was the pioneer to carry out investigatory studies on hemodynamics. Blood is a viscous fluid, and so it flows through the blood vessels very slowly. Veins and capillaries are only passive parts of the circulatory system. They exact considerable peripheral resistance against blood flow, so that blood reaching the heart is practically devoid of any momentum in its own. Moreover, veins are valvular, and so they prevent the reverse flow of blood if the outward flow is obstructed. Heart keeps on beating regularly and rhythmically, pushing the blood into the arteries. This provides the blood the initial pressure and momentum essential for its circulation. Arteries are elastic, and so they extend and relax at every heartbeat. When blood is pumped into the arteries with pressure, their walls dilate momentarily. Very shortly afterwards, the arterial walls recoil, pushing the blood further forward. Before the arterial wall undergoes complete recoiling, another spurt of blood is forced into the artery by the next heartbeat. This process is repeated non-stop, facilitating continuous flow of blood through the blood vessels. So it becomes clear that arteries are always in a dilated state. This dilated condition of elicits the recoiling reaction, where it forms the source of arterial blood pressure. Persistent arterial pressure causes the blood to move forward continuously. Arteries are progressively tapering towards the capillary end, so the arterial pressure never fails. low until the blood reaches the capillaries. Higher arterial blood pressure is necessary for several physiological processes such as glomerular ultrafiltration. On the whole, it becomes clear that blood is kept in constant circulation and proper and constant arterial blood pressure is maintained by a regular and rhythmic heartbeat, regularly beating distension and recoiling of the arterial walls, progressive narrowing of arteries towards the capillary end, and passive squeezing of the veins whose valves prevent the counterflow of blood. The major parameters in circulatory hemodynamics are following: general activity of the animal. The intensity of the activity is the only force that maintains circulation in small and primitive animals. So it is important factor in some regions of highly organized animals, in the lymphatics and small veins of birds and mammals. In cardiac output, the amount of blood pumped in a unit time is related to the blood volume and the force of heartbeat. Then peripheral resistance. This is the resistance against flow in peripheral or terminal blood vessels. It is important in determining the force of circulation. Peripheral resistance is significant in vertebrates and large invertebrates with closed circulation. Velocity of blood flow. The linear velocity with which blood passes a fixed point in the circulatory area, measured in centimeter per second. Volume flow of blood. The amount of blood flowing through the segment of blood vessel, measured in ml per minute. Then circulation time. The time taken by blood to pass from one fixed point to another. That the flow of blood is influenced by several factors such as pressure gradient, driving force, viscosity, the internal friction force of blood against flow, the inertia of mass of blood which is moved and accelerated by heartbeats, and force of gravity, the cohesive force between blood and the wall of the heart vessel, and diameter of the lumen of the blood vessel, etc. Blood always flows in a pressure gradient from an area of higher pressure to a region of lower pressure, and the rate of its flow is largely determined by its viscosity changes. All Newtonian fluids exhibit a linear relation between pressure and velocity of fluid. Blood is a non-Newtonian fluid in that it does not obey the laws of viscosity, and its apparent viscosity varies as a function of the flow rate. The viscosity of blood increases markedly as the flow rate slows down. This is called anomalous viscosity. It's presumably due to the aggregation of erythrocytes. The decrease in apparent viscosity when blood flows through narrow vessels is called Fahrenheit-Lindquist effect. Fahrenheit-Lindquist effect. According to it, the smaller the blood vessel, the lower the viscosity and greater the flow of rate. Next, we are going to learn about cardiovascular problems in man, a very important topic. So, it should be carefully understood. First is about hypotension. Under certain abnormal physiological conditions, human blood pressure fails to below 100 mmHg during systole and or below 60 mmHg during diastole. This persistently low blood pressure is known as hypotension. Hypertension cases are relatively less frequent. They often cause general weakness, easy tiring, headaches, dizziness, pain in the region of heart, etc. Substances such as serotonin and histamine dilate blood vessels and thereby induce hypotension. Low cardiac output, low viscosity of blood and dilation of arteries also contribute to hypotension. Then hypertension. Hypertension is a state of sustained high blood pressure. In hypertension, the systolic pressure is above 140 mmHg and the diastolic pressure is above 90 mmHg. Hypertension is usually accompanied by headache, visual disturbances, tiredness, etc. Nowadays, hypertension cases are much frequent and evidence suggests that mortality and morbidity rates are much higher among patients with diastolic pressure above 85 mmHg. About 12% of people die as a direct result of hypertension, and about 20 to 40% are feared to have it. The actual cause of hypertension is not definitely known. It occurs when the volume of the circulating blood abnormally increases and also when the blood vessels become much constricted or less distensible. So atherosclerosis causes the constriction of arteries and thereby promotes hypertension. Then angiotensin, a protein produced in kidney under the influence of renal enzyme renin, is believed to increase BP and cause hypertension. High cardiac output, high viscosity of blood, reduced arterial lumen, disorders of heart, etc. are also believed to promote hypertension. There are two major kinds of hypertension, namely primary or essential hypertension and the secondary hypertension. So primary hypertension, this is the hypertension without apparent known reasons. It accounts for more than 90% of hypertension cases. Usually it is found in persons above the age of 40 years. It is believed to be hereditary in a disposition caused mainly by congenital kidney disorders. Excessive salt intake, increased salt and fluid and arterial walls, prolonged exposure to stress, etc. also believed to contribute to primary hypertension. Then secondary hypertension, this is mainly due to disorders such as nephritis, kidney stones, atherosclerosis, etc. This kinds of secondary hypertension can be recognized as follows. Systolic hypertension with wide pulse pressure. This is caused by malformations or conditions which increase cardiac output, decrease the compliance of aorta, or decrease the stroke volume of the left ventricle. Then systolic and diastolic hypertension. This is caused by the renal disease, endocrine diseases, or several other non-specific factors. Then malignant hypertension. This occurs when an arterial pressure is markedly high and also when nerves, renal, vascular, and cardiac dilatorations occur over weeks or months instead of years. Then atherosclerosis. Atherosclerosis is a thickening and hardening of the walls of medium-sized arteries. It may occur as a natural change in old age. However, there are some persons it occur earlier. Atherosclerosis is such an excessive deposition of lipids, calcium, and hyaline, a protein. The arterial wall becomes thick and non-elastic, and the arterial lumen becomes narrow. So the blood flow through the affected artery becomes very slow or even blocked. Usually, atherosclerosis produces no symptoms when it occurs in arteries rather than cerebral, coronary, and renal arteries. However, atherosclerosis in cerebral artery may cause cerebrovascular accident, commonly called stroke. So, coronary atherosclerosis may result in coronary thrombosis, angina pectoris, a form of heart disease. Renal atherosclerosis may cause glomerulonephritis. Arteriosclerosis is the arteries to the legs very rarely cause gangrene. The exact cause of atherosclerosis is not definitely known. Hereditary factors, hypertension, diabetes mellitus, etc. are suspected to cause atherosclerosis. Then atherosclerosis and atheroma. Atherosclerosis is an extreme or acute form of atherosclerosis. Then it is characterized by a degenerative condition of the arterial wall called the atheroma. In it, the arterial wall becomes abnormally thick, hard, non-elastic, and brittle, with high deposition of cholesterol and other lipids in the form of plaque and nodes. As the plaques enlarge, the arterial wall thickens abnormally and the arterial lumen becomes extremely narrow, so only very small quantity of blood flows to the part of tissues to which the affected artery goes. As a result, that part becomes ischemic, deprived of sufficient supply of blood and O2. This in turn leads to extensive tissue destruction. Very often, the atheromatic part of the arterial wall ruptures, causing hemorrhage, internal bleeding, and thrombosis, internal blood clotting. This is a fatal condition. Cerebral atherosclerosis often lead to cerebrovascular accident or CVA. So coronary atherosclerosis may cause ischemic heart disease such as angina pectoris. Renal atherosclerosis may cause glomerulonephritis. So some of the suspected causes of atherosclerosis are high blood cholesterol level, hypertension, sugar diabetes, smoking, etc. Old age, obesity, lack of exercise, emotional stress, hereditary diseases, etc. are believed to be contributing factors. The disease is more common among men than among women. Then bradycardia. Bradycardia is an abnormally low rate of heartbeat in which the resting heart rate is below 60 beats per minute. It is more common in older persons. Bradycardia is a seldom symptomatic until rate drops or below 50 beat per minute. Trained athletes tend to have slow resting heart rates, so resting bradycardia in athletes should not be considered abnormal if the individual has no symptoms associated with it. The term relative bradycardia is used to denote the heart rate below 60 beats per minute. There are generally two major problems that may lead to bradycardia, namely disorders of the SA node and the disorders of the AV node. SA node dysfunction is sometimes called a sick sinus syndrome. It may adversely affect the automaticity of the heart or impair the conduction of impulses from the SA node to the surrounding arterial tissue. It is called exit block. Then dysfunction of AV node and the bundle of His may cause disturbances in arterioventricular conduction. Then tachycardia. Tachycardia is the abnormally high rate of heartbeat. It is the form of cardiac arrhythmia which involves the rapid beating of the heart. By convention, the term refers to heart rates greater than 100 beats per minute in the adult patient. Tachycardia may be perfectly normal physiological response to stress. However, in extreme cases, tachycardia can be life-threatening. Tachycardia can be harmful in 3 ways. Once again, tachycardia is an abnormal high rate of heartbeat. So firstly, if the heart is pumping too fast for extending period of time, it will disturb the balance of oxygen and carbon dioxide in the hemoglobin. It is normal during exercise but dangerous in the resting state. Secondly, when the heart beats too rapidly, it may pump blood less efficiently. Thirdly, the faster the heart beats, the more oxygen and nutrient the heart requires. This may leave patients feeling out of breath or cause angina. This can especially be problematic for patients suffering from ischemic heart disease. Then cerebrovascular accident or stroke, commonly called stroke or apoplexy. This is the sudden paralysis or loss of function of one side of the body due to sudden interruption of blood supply to a part of the brain. Stroke is usually uncommon before the age of 50 years. Since then, becomes more common with increasing age. The commonest symptoms of the stroke are the following: paralysis or weakness of one half of the body, inability to speak, write, read, and understand speech, difficulty in swallowing, confusion, drowsiness, depression, and involuntary urination, and loss of consciousness with severe attack. The main causes of stroke include cerebral hemorrhages, cerebral thrombosis, cerebral atherosclerosis, heart diseases, etc. There are two main types of stroke, namely complete stroke and transient stroke. The former is severe and recovery from it is only slow and partial. The latter is relatively mild and recovery from it is quick and complete, but it may keep on relapsing. Then cerebral hemorrhage. Cerebral hemorrhage is a bleed into the substance of the cerebrum. Cerebral hemorrhage can lead to hemorrhagic strokes, and so they are medical emergencies. This can happen from epidural hemorrhage, subdural hemorrhage, supraarachnoid hemorrhages, and intracerebral hemorrhage. Then intracerebral hemorrhage or ICH accounts for 10 to 15% of all strokes. It most frequently results from high blood pressure as found in people with hypertension, abuse of some drugs, etc. ICH has a mortality rate of 44% after 30 days, higher than that of ischemic stroke, and is very deadly subarachnoid hemorrhage. The symptoms of intracerebral hemorrhage include headache, nausea, vomiting, and changes in verbal skills, balance, swallowing, coordination, focusing the eyes, etc. Subarachnoid hemorrhage, which accounts for 5 to 10% of strokes, is one of the deadliest type of strokes. Subarachnoid bleeds kill 40% of the victims and disable half survivors. When a vessel in the arachnoid layer of the meninges bursts, the blood enters subarachnoid space where subarachnoid fluid baths the brain, contaminating it. Since the brain is quite sensitive to changes in pH, extensive damage can result when the chemical balance of CSF is disturbed by the body blood. Then it's about cardiac arrest. Cardiac arrest is the cessation of normal circulation of blood due to failure of the ventricles of heart to contract effectively during systole. The resulting lack of blood supply results in heart death from oxygen starvation. Cerebral hypoxia, or lack of oxygen supply to the brain, causes the victims to immediately lose consciousness and stop breathing. Cardiac arrest is a medical emergency that, if left untreated, invariably leads to death within minutes. The primary first aid treatment for cardiac arrest is cardiopulmonary resuscitation. So it apparently healthy adults, cardiac arrest is often caused by ventricular fibrillation during myocardial infarction, heart attack. In children, cardiac arrest is typically caused by hypoxia from other causes such as near drowning. With prompt treatment, survival rates are high. Every fatal injury or illness ultimately terminates in cardiac arrest, which is a natural part of the process of death. Then Heart failure. Congestive heart failure or CHF, also called congestive cardiac failure or CCF or just heart failure, is a condition which can result from any structural or functional cardiac disorder that impairs the ability of the heart for fulfilling and pumping. It is not to be confused with cessation of heartbeat or with cardiac arrest. The former is a state of asystole, whereas the later is a cessation of normal cardiac function with subsequent hemodynamic collapse and eventual death. Even when the best therapy, heart failure accounts for an annual mortality of 10%. It is leading cause of high hospitalization in people above the age of 65 years. Then myocardial infarction. You probably might have heard this term. Nothing else, just heart attack. The myocardial infarction or heart attack is a very serious form of ischemic heart disease characterized by extensive damage or death of heart muscles. Then infarction is the death of an area of tissue due to lack of blood supply. In myocardial infarction, supply of blood and O2 to a particular portion of heart fails abnormally low. This is called cardiac ischemia or ischemic heart disease. The muscles of that part die within a few minutes due to lack of O2. This is known as myocardial infarction. This may cause disabilities or death of the person. There are two main causes for myocardial infarction, namely ventricular fibrillation and coronary thrombosis. Both this prevent the supply of blood and O2 to the heart walls. In ventricular fibrillation, the ventricles contract rapidly but without pumping blood. Then angina pectoris. Angina pectoris is a state of severe chest pain due to ischemic heart disease or myocardium, insufficient supply of blood and oxygen to heart muscles. Mostly results from reduced coronary circulation and coronary diseases such as spasms of coronary arteries, coronary thrombosis, coronary atherosclerosis. This disease has considerably reduced the lumen of coronary arteries and thereby lower coronary circulation and cause myocardial ischemia. Constant stress, which causes constriction of vessel walls, strenuous exertion or heavy work immediately after heavy meal, exposure to cold, etc., are the aggravating factors which add to the severity of angina pectoris. Angina pectoris is predominantly a disease of middle age and it is more common in men than in women. Though it weakens the heart muscles, it may not produce a full-scale heart attack. The more characteristic symptom of angina pectoris is acute pain behind the breastbone. The pain often spreads into left arm. In most instances, it is so severe that the affected person is unable to continue any exertion. However, the paroxysm of pain seldom lasts for more than a few minutes, provided the affected person is at complete rest. The administration of nitroglycerin, which would dilute coronary vessels and thereby increase blood flow to heart, may give temporary relief of the pain. Then is about electrocardiography or ECG. Then angioplasty is also discussed along with angiography. Later we will be dealing about lymphatic system, a short essay about lymphatic system, which will be performed with the help of the next video. So electrocardiography is an imaging technique used for studying the functioning of the heart by recording the electrical activity of heart muscles. It gives correct information regarding the rhythm and rate of heartbeat and has helped to detect disorders of heart. The instrument used for electrocardiography is called electrocardiograph. Its technique was first applied by Enthoven in 1903 and hence he is regarded as the father of electrocardiography. Heart muscles are always in a state of intermittent excitation, so there is a never-ending flow of impulses over the heart walls. This in turn causes the generation of electrical potentials which spread over heart walls and neighboring tissues. These are called action potential or action currents. They can be recorded on the graph paper with the help of electrocardiograph. A person is connected to this instrument by electrodes and leads to electrodes are connected to its arms, legs or different parts of chest. The tracing of the graphic record of the electrical phenomena in the heart is called electrocardiograph. Currently, sophisticated types of multi-channel monitor systems are used for recording the electrical activity of cardiac muscles. The electrocardiogram of a perfect normal human heart is called normal electrocardiogram. It has a characteristic wave pattern. The graph of such normal heartbeat or cardiac cycle will have 5 characteristic waves, P, Q, R, S and T. Of this P, R and T are upward waves, Q and S are downward waves. And P wave represent the excitation of depolarization of the auricular muscle, therefore called auricular complex. The magnitude of the P wave reflects the functional efficiency of the SA node. QRS and T waves represent the initiation and spreading of excitation and depolarization of ventricular muscles. So they constitute the ventricular complex. Q wave is believed to represent the excitation of papillary muscles. R wave represent the excitation of the base of the ventricle. S wave represent the excitation of the apex of the ventricle. And the T wave represent the end of ventricular excitation. Thus, the interval between P and Q waves represent auricular systole, and that between Q and T represent ventricular systole, and P and R interval represent the time required for the spreading of excitation from SA node to the ventricle. Any abnormalities in the contour of waves in an electrocardiogram indicates a disorder in the heart. For example, a P wave having two summits indicates the hypertrophy of the left auricle, increase in thickness of mitral stenosis, narrowing of mitral valve, irregular fluctuations or oscillations of the P wave indicate auricular fibrillation, rapid contraction due to excessive excitation resulting in extremely irregular heartbeats and pulse. An abnormal Q wave indicates myocardial infarction. So lengthy PR interval indicates heart block. ECG is now used to measure the rate and rhythm of heartbeat and detect the damage of heart muscles and to diagnose heart disease. It is important in the diagnosis of the following: auricular flutter, abnormally high rate of systole, arrhythmias, abnormal variations in the rhythm of heartbeat, then heart blocks, myocardial infarction, then angina pectoris, then hypertrophy of heart chambers. Next topic is angiography. Angiography is an investigation technique by which blood vessels are rendered visible on the X-ray film by injecting a radio-opaque substance into them. The X-ray of heart after injecting a radio-opaque substance to it is called angiocardiogram. The angiocardiogram of the arteries is called arteriography, and that of veins is called venography and or phlebography. So angiography is significant in that it reveals where there is any narrowing, stenosis of the lumen of the blood vessel. Angiography is essentially a catheter investigation, and a catheter is introduced into the direct side part of blood vessel, and the radio-opaque substance is injected to that part of blood vessel. It sweeps along the blood vessel, fitting the full diameter and length of the vessel. The image of this vessel in the X-ray clearly shows whether the blood vessel has become narrow or it is completely blocked in any part. Coronary angiographic mapping of coronary arteries nowadays are highly useful in the detection of cardiac problems. It clearly marks out the exact location of any obstruction in the coronary artery and also reveals its severity. This information in turn enables to bypass the surgery of the diseased part. Then angioplasty, commonly called balloon angioplasty, is the technique of dilating blood vessels, especially coronary arteries, by the inflammation of a small balloon catheter. This technique involves inflating a tiny balloon inside the partly obstructed blood vessel, forcing the fat deposit back to the wall of the vessel. Balloon angioplasty was first successfully employed for removing obstructions in the arteries to legs. From 1979 onwards, it is used as a routine procedure for removing obstructions in coronary artery. In coronary balloon angioplasty, a fine tube balloon catheter is introduced into the affected coronary artery. Then liquid is pumped into the balloon until it is fully expanded. This breaks the hard atheroma deposit and crushes it against the arterial wall. Balloon inflammation usually lasts 15 to 30 seconds using a pressure of 4 or 5 atmosphere. During this, the flow of blood through the artery may be completely blocked for a short while the heart muscle can tolerate. In the majority of cases, balloon angioplasty has long-term beneficiary effect. However, in the nearly 30% of patients, narrowing of the affected artery recurs. That means reoccurring happening. And then often at the same point. If such a restenosis occurs, angioplasty may be repeated. Balloon angioplasty is often suggested as a treatment for angina. If the symptoms are not controlled by drugs, angioplasty is very useful in removing internal clots in blood vessels. In this case, clot dissolving drugs are injected to the balloon. So balloon angioplasty is simple and attractive in that it helps the patient to avoid the of surgery and prolonged medication and hospitalization. Still, then it is not free from risk. There is a mortality rate of around 1%. Mortality rate. And in a sense, death rate. So in a sense, Balloon angioplasty is a crude technique since it damages the delicate artery wall. It is countered with administration of drugs to prevent blood clotting and to limit the clumping of platelets inside the vessel. Balloon angioplasty, dilating the blood vessels. A fine tube balloon catheter is introduced into the affected coronary artery, then liquid is pumped into the liquid until it is fully expanded. This breaks the hard atheroma deposit and crushes it against the artery wall. Or usually this is treatment. This treatment is used for angina.